Hello friends, welcome to Creative Medicine. In this lecture, we will learn about
Then we have Weber syndrome. In Weber syndrome, there will be ipsilateral third nerve palsy with contralateral hemiplegia will be seen in Weber syndrome. There will be ipsilateral third nerve palsy with contralateral hemiplegia is seen in Weber syndrome. Then we have north angle syndrome. So what do you see in north angle syndrome? In this you will see ipsilateral third nerve palsy along with the contralateral ataxia. Along with that you will see contralateral intentional tremors. You will see ipsilateral third nerve palsy, contralateral ataxia with contralateral intentional tremors are seen in north angle syndrome. Then we have Benedict syndrome. Benedict syndrome. So what do you see in Benedict syndrome? Ipsilateral third nerve palsy plus contralateral chorea testing tumors, chorea and tremors are seen. You can see ipsilateral third nerve palsy with contralateral chorea and tremors are seen in Benedict's syndrome. Okay, next we have to see penialoma. So what does penialoma do? See, if you see, this penialoma is mainly seen in the midbrain. So in the midbrain, first we have, this is the picture of the midbrain. Here we have substantia nigra. Okay, this all is substantia nigra. Then you can see red nucleus here. And then you can see this is the cerebral aqueduct in the midbrain. Okay, and then there will be third. One minute, draw it a little. Oh yeah, this is the cerebral aqueduct. Okay, and here you will see the third nerve nucleus, which is Edinger-Westphal nucleus is seen. So this is Edinger-Westphal nucleus. Okay, then from the Edinger-Westphal nucleus you will see that the third nerve will emerge. So this is third nerve. Then you also have fourth nerve, but this fourth nerve will emerge dorsally and it will cross. So this is fourth nerve which is coming. Okay, and then yeah, so these are the important things. Now if there is and one more thing, here you will see presence of superior colliculus. Okay, so this is at the level of superior colliculus. Okay, now this Weber's, so this midbrain is supplied by branches here, supplied by branches of the artery like this. Okay, now I will label all this. So if there is a lesion, okay, pineal gland lesion, penialoma will be seen here. Okay, now if there is pineal gland lesion, here you will see pineal gland. So this is pineal gland. Okay, if there is any lesion or if there is an enlargement, penialoma, where if there is enlargement of pineal gland, so this will compress the fourth nerve, right? When this fourth nerve is compressed, okay, fourth nerve, so pineal gland, penialoma will compress the fourth nerve. So when fourth nerve is compressed, this is SO4 LR6. So superior oblique is compressed. So superior oblique is compressed. So as a result, so superior oblique is lost. So there will be impaired vertical gaze will be seen. Okay, there will be impaired vertical gaze will be seen, and you see upward gaze. And this upward gaze which you see is called as sun setting sign. You will see it as sun setting sign. Okay, then this syndrome which occurs where you see sun setting gaze is called as Paranod syndrome. Okay, so this is Paranod syndrome. Then we will also label the other syndromes here. So if there is any defect in the this one, in the red nucleus, if there is any defect, this will result in Benedict syndrome. So because it's Benedict syndrome, occurs whenever there is defect in the red nucleus and the third nerve. So whenever there is Benedict syndrome, there will be ipsilateral third nerve palsy along with the, because of the lesion in the because of the lesion in the red nucleus, it will result in contralateral chorea. Okay, then if you see Northingal syndrome occurs due to the defect in here. Whenever there is defect in substantia nigra, then that will result in Northingal syndrome. This substantia nigra, whenever there is defect in the substantia nigra, then it results in the Northingal syndrome, and even third nerve is also involved here. So it causes first ipsilateral third nerve palsy with contralateral ataxia, gait and intentional tremors. So it causes ipsilateral third nerve palsy with contralateral ataxia and contralateral intentional tremors. So this is Northingal syndrome. Then we have Weber syndrome. Weber syndrome occurs in this area. Here in this area, you will see presence of pontine fibers, and also all the fibers which are ascending up will be present here. So if there is lesion here, it causes Weber syndrome, and whenever there is Weber syndrome, there is third nerve palsy. Along with that, there will be contralateral hemiplegia is seen. Okay, so these are the midbrain syndromes. Now, after midbrain syndrome, we have Pons. Okay, so in the Pons, this is the pontine nucleus. This is the center. Here you have corticospinal pathway. Corticospinal pathway will be there. Sorry. Okay, we will see first pons, that is medulla. First we will see pons. In the pons, so same, yeah, sorry, I can draw it with this. So this is corticospinal pathway will be there, and also there will be two nerves which are coming. Two nerves, yeah. One is sixth nerve and the other is seventh nerve. So we have sixth nerve nucleus here, and this is seventh nerve. So whenever there is a lesion here, think that there is a lesion involving the medial part of the pons here. This lesion in the medial part of the pons. This lesion in the medial part of the pons, this is called as Millard-Gubler lesion. Millard-Gubler lesion. In this Millard-Gubler syndrome, there will be number 1 ipsilateral sixth nerve palsy, and there will be ipsilateral seventh nerve palsy, and there will be contralateral hemiplegia due to the involvement of corticospinal tract. So in Millard-Gubler syndrome, you will see ipsilateral sixth nerve palsy, ipsilateral seventh nerve palsy, and contralateral hemiplegia is seen in Millard-Gubler syndrome. Then we have medulla. Okay, then if you see medulla, it is something like this. Okay, so if there is any lesion in medulla, where first we will see what are there. So first there is here, you will have corticospinal pathway. Okay, now medially, this is corticospinal pathway. Medially, you will have here, you will have in the medulla, medially you will have 12th nerve. Okay, and then laterally, if you see, number 1, you will have nucleus ambiguous. This is nucleus ambiguous, which contain 9th, 10th and 11th nerves. So nucleus ambiguous is there. Then we have nucleus tractus solitarius. This is nucleus tractus solitarius is present, which is 7th, 9th and 10th nerve. We have nucleus tractus solitarius is present. Then we have here 5th nerve is present, and here you will see presence of sympathetic chain is seen. Okay, so these are the main things which are seen here. Okay, now there are two syndromes which are seen in This one we have medial medullary syndrome, second we have lateral medullary syndrome. If there is medial medullary syndrome, that is lesion here. This is medial medullary syndrome. If there is medial medullary syndrome, there is involvement of the corticospinal tract. So there will be contralateral hemiplegia. Along with that, there is involvement of 12th nerve. So there will be ipsilateral 12th nerve palsy is seen in medial medullary syndrome. Then if this is involved, if this part is involved, then this leads to the lateral medullary syndrome. In lateral medullary syndrome, there will be involvement of the 5th nerve, 7th, 8th, 9th, 10th and 11th nerves are involved. Here 5th, 6th, 7th, 8th, 9th, 10th, 11th nerves are involved in lateral medullary syndrome. Okay, next. What are the syndromes which will cause hemiplegia? Hemiplegia is caused by middle cerebral artery lesion. It is caused by P1 PCA, that is P1 branch of the posterior cerebral artery, that is nothing but Weber syndrome, will result in hemiplegia along with Turner palsy. Then it will also cause by basilar artery syndrome, that is we have Miller-Gubler syndrome. In Miller-Gubler syndrome also, Miller-Gubler syndrome which is caused by 6th and 7th nerve palsy, even this you will see hemiplegia. Then anterior spinal artery. In anterior spinal artery syndrome, that is medial medullary syndrome. Medial medullary syndrome caused by the anterior spinal artery, even here you will see hemiplegia along with the 12th nerve. Hemiplegia along with the 12th nerve, medial medullary syndrome, anterior spinal artery. Hemiplegia along with the 6th and 7th nerves, it is Miller-Gubler syndrome, basilar artery. Hemiplegia along with the 3rd nerve, that is Weber syndrome, that is P1 branch of the posterior cerebral artery. Okay, then finally posterior inferior cerebellar artery, which is lateral medullary syndrome, which is caused by the along with 5th, 7th, 9th, 10th, 11th nerves will cause lateral medullary syndrome. It will also cause hemiplegia. Okay, so these are the different differential diagnosis of hemiplegia. Next, we have lateral medullary syndrome. Lateral medullary syndrome is also called as Wallenberg syndrome. In lateral medullary syndrome or Wallenberg syndrome, the vessel involved is vertebral artery is the one which is involved, followed by posterior inferior cerebellar artery. Vertebral artery is involved, followed by posterior inferior cerebellar artery is involved. First, there is involvement of different structures. If the restiform body is involved, so it will cause ipsilateral ataxia. Okay, sympathetic chain involvement will result in Horner syndrome. Because of sympathetic chain involvement, it causes Horner syndrome, where you see ptosis, meiosis, enophthalmos, enhydrosis, loss of ciliospinal reflex is seen. There is 5th cranial nerve involvement along with the involvement of lateral spinothalamic tract. As a result, there will be contralateral pain and temperature is seen in the patient. Because of involvement of lateral spinothalamic tract, there will be contralateral pain and temperature which is seen in the patient. Then, involvement of 7th nerve and 9th nerve sensory causes taste sensation is lost, causing ageusia is seen. Then, involvement of 9th nerve palsy will result in nasal regurgitation. 9th nerve palsy will result in nasal regurgitation and also nasal twang to voice is seen. Then we have 10th nerve palsy. 10th nerve palsy will control the heart rate. It will control the heart rate. Normally 10th nerve controls the heart rate. So but because of loss of control, palpitations is seen in 10th nerve palsy, and also stomach motility is seen due to 10th nerve palsy. I'll tell you. 10th nerve is important in controlling the heart rate. It controls the stomach motility. Then it also controls the GIT motility, that is peristalsis is by 10th nerve. It also important for gag reflex and also vocal cords. All these are actually controlled by 12th nerve. So when there is palsy in the 12th nerve, then this will result in palpitations instead of controlling the heart rate. Because of stomach motility, it will result in gastroparesis can occur. And in GIT motility, it can cause constipation, and because of gag reflex is lost, it can cause choking and aspiration of the patients, and vocal cords are lost, so this can result in dysarthria in the patient. Then if there is 11th nerve palsy, this 11th nerve palsy will result in spinal accessory nerve. Okay, this will also cause, when this is 11th nerve is spinal accessory, so this will result in shoulder drooping also. So these are the different things that occur in lateral medullary syndrome. Then what is transient ischemic attack? Transient ischemic attack is if the patient develops the symptoms of loss of weakness, if the patient develops weakness in any part of the body, especially if the symptoms of stroke, or else if the symptoms of stroke are less than 24 hours of time, then we call it as transient ischemic attack. And during this transient ischemic attack, if you do imaging, the imaging will be found to be normal during the transient ischemic attack. Okay, so the symptoms in the transient ischemic attack mainly depends upon the artery involved. So for example, if it is ophthalmic artery is involved, so if ophthalmic artery is involved, it will result in transient blindness. If ophthalmic artery is involved, it will result in transient blindness, or it will result in amaurosis fugax. Okay. Next, if there is middle cerebral artery injury involvement, then it will result in arm weakness. Middle cerebral artery involvement will result in arm weakness or facial weakness, or it can result in aphasia. Middle cerebral artery involvement will result in arm weakness, facial weakness, and aphasia. Then anterior cerebral artery involvement will result in paraplegia. Anterior cerebral artery involvement will result in paraplegia. Then vertebral artery involvement. So if you see, vertebral artery involvement will result in nasal regurgitation of fluids. Vertebral artery involvement will result in nasal regurgitation of fluids. Then also you will see pins and needle sensation will also be seen. Okay, so these are the different symptoms which can be seen. Even more symptoms can also be seen. Then here we have a score which is available for this. For measuring stroke, we have a score which is called as ABCD2 score. This ABCD2 score will predict the stroke. The maximum score for this ABCD2 is 7 score. Okay, so in this, what is this score? So it is A, B, C and D. Okay, if the age is more than 60 years, then it is 0.1. B is BP. If the patient has blood pressure of more than 140/90, then it is score is 2. Then if the patient has arm weakness, then the score is again 2. If the patient has aphasia minus arm weakness, if the patient has aphasia minus arm weakness, it is 1. If the duration is less than 10 minutes, then it is 0. If the duration of the stroke is 10 to 59 minutes, then it is 1. If the duration of stroke is 60 minutes, then it is 2. If the duration of TIA is 60 minutes, then it is 2. If diabetes mellitus, then it is 1. Okay. So A, B, C, D score, which is A for age more than 60 years, 0.1. B, PP is more than 140/90, score 2 is given. Then clinical features, like if there are arm weakness, then you give 2 points. If there is aphasia minus arm weakness, only aphasia is seen without arm weakness, then you give 0.1. And then if there is the duration, next, the duration is less than 10 minutes, then 0. 10 to 59 minutes, then it is 1. If the duration is more than 60 minutes, almost 60 minutes, then it is 2. Then diabetes mellitus, you give 1. Now, this is ABCD2 score for predicting the stroke. If maximum score is 7, then it is positive. Yeah, maximum score will be 7. Next, what will you do if a patient comes with TIA? First, you will do ECG. ECG is done mainly to rule out atrial fibrillation. Then you will do transthoracic echocardiography or transesophageal echocardiography. Both transthoracic echocardiography or transesophageal echocardiography are mainly done to rule out the mural thrombus. They are done to rule out the mural thrombus. Then we have carotid artery Doppler. This carotid artery Doppler is done. Then we have lipid profile is seen. In the lipid profile, you will see there is increased levels of LDL, VLDL and HDL will be seen. And also you will also see increased homocysteine is seen. Okay, so what do you do in workup? In workup, you do ECG. ECG is done mainly to rule out atrial fibrillation. Transthoracic echocardiography or transesophageal echocardiography are done mainly to rule out the mural thrombus. Then you can do carotid artery Doppler. Then you can do lipid profile should be done mainly to see if there is LDL, VLDL and HDL levels. Then you do homocysteine will be increased. Now, if you see the treatment, in treatment, you will give tablet aspirin is given to the individual. 300 milligrams of tablet aspirin is given along with tablet clopidogrel is given to the individual, which is again 300 milligrams. 300 milligrams of aspirin and 300 milligrams of clopidogrel are given. Followed by you give aspirin of 75 milligrams and clopidogrel of 75 milligrams is given lifelong. You give aspirin of 75 milligrams and clopidogrel of 75 milligrams is given lifelong. So in the treatment, first you give tablet aspirin 300 milligrams, plus tablet clopidogrel 300 milligrams is given initially. Dual platelet, this therapy we call it as dual platelet therapy. So this is dual platelet therapy, and followed by you should give 75 milligrams of aspirin and 75 milligrams of clopidogrel should be given lifelong. And to this, you can also add atorvastatin. You can add atorvastatin can be added, which is a statins, and you can add B6, B9 and B12 is added. And also you can add rivaroxaban. Rivaroxaban or dabigatran. Rivaroxaban or dabigatran, which are novel anticoagulants, can be added. Rivaroxaban or dabigatran, which are novel anticoagulants, are also added to this list. Then let us take a case scenario. There is a 60-year-old male who has hypertension and who is also a smoker. At 6 a.m. he is actually walking, and at 6:30 there is sudden onset. At 6:30 there is sudden onset of aphasia, and also there is right arm weakness is present. There is sudden onset of aphasia with right arm weakness. Then in 7:30 a.m. in the hospital. He is in the hospital in 7:30 a.m. And then in the 7:30 a.m. you will see that deep tendon reflexes are brisk. You will see presence of brisk deep tendon reflexes, and you will see presence of upgoing plantars are also seen. You will see deep tendon reflexes with upgoing plantars are seen. And if you do fundus examination in this patient, it will be normal. Now he has come at 7:50. At 7:50, that means in the hospital it is 7:30, now 7:50, it is almost 20 minutes. Now at 7:50 a.m. you should do CT scan. Always remember door to CT scan time. That is from the time when they come to the emergency department at 7:30 he came to the hospital. So he came to the emergency department at 7:30. From there to the time when you do CT scan, it should be less than 20 minutes. Okay, door to CT scan time, that is door to the CT scan time should be less than 20 minutes. And if you see door to CT scan interpretation time, door to CT scan interpretation time will be less than 45 minutes. Door to CT scan interpretation time will be less than 45 minutes. So number 1, door to CT scan time will be less than 20 minutes, and door to the CT scan interpretation time will be less than 45 minutes. Door to CT scan time will be less than 20 minutes, and door to CT scan interpretation time will be less than 45 minutes. Now you have interpreted it. Now in CT scan there can be 2 things can occur. One, there can be CT scan, you might see some hypodensity at a region. One, you can either see hypodensity at an area, or you can either see hyperdensity at some place. One hypodensity can be seen or hyperdensity is seen. If there is hypodensity, then it is ischemic stroke. If there is hyperdensity, then it is hemorrhagic stroke. Then first, if there is ischemic stroke. If there is ischemic stroke, the drug of choice is you can do retiplase can be used if there is ischemic stroke. The window period for retiplase should be less than 4 hours 30 minutes, 4.5 hours. The window period should be less than 4.5 hours of symptom onset. And brain angiography should be 4.5 to 6 hours. So in ischemic stroke, acute ischemic stroke, the window period should be less than 4.5 hours of symptom onset and brain angiography will be 4.8 to 6 hours. So window period will be less than 4.5 hours of symptom onset and brain angiography will be 4.5 to 6 hours. So you give retiplase. Next, this is for acute ischemic stroke. Then if you see, it is a hemorrhagic stroke. Remember, for this hemorrhagic stroke, these retiplases or any type of thromboplastin inhibitors are actually antifibrinolytics are contraindicated in hemorrhagic stroke because already there is hemorrhage going on in the brain. So if you should not give even more fibrinolytics should not be given to the patient. So in hemorrhagic stroke, there will be increase in intracranial pressure. You will see because and you should give osmotherapy should be given because there is increased intracranial pressure. You should give osmotherapy and you should give ventriculostomy should be done. Osmotherapy is given and ventriculostomy should be done. If this ventriculostomy fails, then you should do hemicraniectomy is done. If this ventriculostomy fails, then we should do hemicraniectomy, that is decompressive hemicraniectomy is done. Then in hypertension crisis, if there is any hypertension crisis, if the patient has hypertension crisis, then you should give nicardipine is given and also nicardipine is given and also labetalol is given. For hypertensive crisis, we give nicardipine and labetalol is given. Then thrombolysis. So in thrombolysis, if you see, thrombolysis should be given if it is ST segment elevated MI, it should be given less than 12 hours. If it is acute ischemic stroke, then it should be given less than 4.5 hours. And it is also given per massive pulmonary embolism also we do thrombolysis. So for ST segment elevated MI, it should be given less than 12 hours. For acute ischemic stroke, it should be given less than 4.5 hours. So what are the contraindications of thrombolysis? Non-ST segment MI, you should not give thrombolysis. Hemorrhagic stroke is a contraindication for thrombolysis. Pulmonary embolism, not massive, and also systolic blood pressure more than 185. And also diastolic blood pressure more than 110 millimeters of Hg is also a contraindication. So systolic blood pressure more than 185 and diastolic blood pressure of more than 110 is also a contraindication for thrombolysis. In both among this ischemic and hemorrhagic stroke, this ischemic stroke is more common when compared to hemorrhagic stroke. So, what are the causes of hemorrhagic stroke? Hemorrhagic stroke can occur due to hypertension, it can occur due to trauma or warfarin toxicity. It can occur due to hypertension, trauma, warfarin toxicity, or it can also occur due to cerebral amyloid angiopathy. It can occur due to cerebral amyloid angiopathy. This can occur. So, hemorrhagic stroke can occur due to hypertension, trauma, warfarin toxicity, and cerebral amyloid angiopathy.
Thank you and thank you for watching.